it's a pleasure for me to introduce to you Cecilia and leave the floor to her presentation. The presentation will last about half an hour and then we'll come back for Q&A. Thanks for joining us.
Thanks so much, Giuseppe, and thanks to the entire CPC for the invitation today. So in terms of introduction, you kind of know where I am. I co-direct the Rapid Research Evaluation and Appraisal Lab with Dr. Ginger Johnston, who's another medical anthropologist. And today, one of the things I wanted to cover was basically, I guess, combine two different things. So present a general overview of what we mean by rapid qualitative research, as I thought that might be an area of interest, and it's kind of the main area of focus of our team, but also bring into the discussion some of our experiences and our learning while trying to apply rapid qualitative research approaches during the COVID-19 pandemic. So hopefully that will be interesting. And I want to start today just with a general introduction of our team. And I think it's important to get an idea of what the team does and our main areas of interest, because all of this will be linked to the projects that I'll talk about today. So instead of me describing the team, I've got a little animation. I'm going to see if technology will collaborate with me. Let me.
The Rapid Research Evaluation and Appraisal Lab uses research to improve healthcare systems, programs, and interventions delivered in time-sensitive contexts. REAL is a multidisciplinary team with expertise in qualitative and quantitative research. REAL delivers face-to-face and online training, carries out rapid literature reviews, quick appraisals, rapid ethnographies, and evaluations, and advises other teams or organizations on the use of rapid research approaches. Current areas of research include the organization and management of healthcare delivery, the use of rapid qualitative research in clinical trials, global health and complex health.
I knew that was going to happen. Sometimes when our internet connection isn't working well, we get that problem. All right. That was almost the end of it, though, so most of it. So the idea of just giving you that overview so you can understand where we're coming from in terms of the type of research that we do. And as you can see, our team's interest is really around what we might call applied health research, where the idea is that we can generate findings that can be used to inform changes in policy and practice, and where it is important to be able to deliver findings from our studies that can be used to inform decision making. So one of the first things that I would like to talk about, and this links a lot with some of the stuff that we've been doing during COVID-19, is a bit of history around how we actually got involved in some of these projects and why we became interested in rapid qualitative research approaches. And I guess I have to take you back to around the time of the Ebola epidemic, and we were doing some work with my colleague who I've mentioned before, looking at, we were asked by UNFPA to do a piece to look at the relationship between gender and incidence of disease during this time, and really trying to bring in lots of the research that had taken more of a social-cultural kind of perspective to try to examine the roles that particularly women were playing during this epidemic around caring both inside the home and outside as well. And what we were seeing around this time as we engaged with some of the literature was actually that there were lots of social scientists from many different disciplines really actively trying to inform epidemic response efforts. And Ebola was quite interesting because lots of platforms, so I've put a few examples here, were developed at the time to generate really rich qualitative pieces of work, providing insight into various different aspects of disease spread. And And even though that infrastructure existed, we were also starting to hear conversations of our colleagues referring to many situations where there were many missed opportunities for actually using some of this evidence to inform epidemic response efforts. And we started doing some work trying to think about, well, why were these missed opportunities generated? What was happening? And in some cases, you know, some colleagues talked about the fact that social scientists don't normally have a seat at the table when decisions are made, or we are asked to come in when it's already too late. And without negating the fact that is many times the case, what we were also seeing was that when social scientists were asked to produce pieces of work that could be used to inform these response efforts, they were normally talking about very kind of complex and sometimes very long-term research designs that wouldn't be appropriate to inform epidemic response efforts on this kind of ongoing basis. So there was something there around timeliness, right? And there was also something there around the formats that were being used to share those findings. So, you know, relying normally on reports that are incredibly long, very kind of text-based, that couldn't really be easily digested and transformed into some sort of action. So this kind of failure to some extent to be able to share what we call actionable findings so that they could be immediately incorporated into response efforts. So quite a few things there that we started thinking about, and we published this review that you see here to actually start to look at, well, you know, the people who have started to use some of these more rapid approaches, what does that actually look like in the context of a complex health emergency? So as a result of that, we came across some of the early work that had been carried out on rapid qualitative research, and here just referring to some of the work that Scrimshaw Hurtado carried out. And they posed this question over 30 years ago, so quite a long time ago now, but it's a question that our team has kind of been reflecting on for several years. So this question of must one spend a year in the field collecting ethnographic data, so this kind of looking at it from an anthropological point of view, in order to make useful recommendations for a health program. And what we're finding is actually that many times when we can, without negating the fact that some topics and some context, you will only be kind of adequately studied with more traditional longer term research designs. There's many, many different things that can be done within shorter timeframes as well. And in order to be able to do that, we need to consider timeliness. So like McNally and colleagues argue here, considering timeliness as a component of the type of research that we're doing. So just reflecting on the experience of Ebola, in many ways, timeliness there was very, very closely linked to the utility of research. Lots of the work that we do, our findings can inform decision-making only if they're shared at a particular point in time, but also, and this is, I think, relevant for many topics, but very, very visible during COVID-19. Some topics are also time sensitive. So if certain processes, events, perceptions are not captured at a specific moment in time, then the richness will be lost, and capturing them in a retrospective way is not always the same. So that's also another reason to consider an issue of timeliness when talking about research. And before I actually start talking about the COVID-19 work, just because not everyone's familiar with rapid methods, I just wanted to give, I've got a few slides giving you a general overview. And really, this is a field that's relatively old. I mean, lots of people think these are new approaches, but they're actually not. And we've started seeing examples, some examples even from the 1950s, but quite a few different rapid research approaches developed around the 1970s and 80s. And if you're just starting out and you're interested in finding more, there's this really good review by McNally and Foster-Fishman where they carry out an overview of what they call REAM, or Rapid Research and Evaluation Methods. And the reason for creating this kind of overview of the literature is that they wanted to identify the core elements of this kind of field of research. And for them, it's mainly the four ones that I've circled down here. So we're talking about research approaches that are rapid in the sense that the studies are carried out anywhere from a few weeks to a few months. They have some layer of participation in the sense that they might be involving community members in some of the design. It might also be other stakeholders that they involve in the design, some of them even during the implementation of the study. Many of them are team-based, and teams are used for different reasons, to potentially cover more ground in terms of data collection over a shorter amount of time. But also you can develop teams where you've got people from different disciplines, for instance, or that have different types of knowledge. And so you're kind of bringing all of that into the study, and that could shape how you're carrying out both data collection and analysis. But also, having said that, many of these approaches are team-based. There's also quite a few that we've identified that rely on what we call more of a lone researcher model, or where there's an individual researcher mainly doing most of the work. So that's another core element. And the last one, which I think is one of the key ones of these types of approaches, is the fact that they're based on iterative research design. So iterative meaning that there's various kind of repetitive cycles that are part of this, of the research process. Many times data collection and analysis are carried out in parallel. And there's this kind of ongoing sharing of emerging findings, and all of that is contributing to the interpretation, the overall interpretation of the findings, but can also lead to considering making changes in study design as the study is still ongoing. So those are, I guess, to date, the core elements that have been used to define these approaches. And the other question I always get is, what do you mean by rapid? And unfortunately, there's also no real consensus out there in terms of what we mean by rapid, or where do we draw the line between more rapid and more long-term. I've included a few timeframes here from the literature as a guide, but what we see in practice is actually quite a bit of variability. And we also see lots of variability in relation to different rapid research approaches. Here I've just listed a few. There's several missing, but at least this gives you an idea of some of the approaches, the most popular ones out there. And I've divided them by those that are used more within kind of a research landscape versus an evaluation landscape. And you know, they share quite a few characteristics, but they also have their own unique contributions, I guess. And some of the characteristics that they share are listed here, and you'll see that some of these resonate with what I was mentioning before in the review by McNally and Foster-Fishman. But some key things to consider, and you'll see this when I talk about our study as well. In order for these studies to be rapid, many times what they do is they need to be working with quite focused or targeted research questions. And in order to kind of achieve that level of focus, there needs to be some sort of preparatory, or something we call this a scoping stage. So kind of a preliminary piece, potentially trying to understand the context a bit better, what has already been done, even to start interacting with people who might later become participants in a study, engaging with stakeholders. So quite a collaborative approach to some extent to research design, and working together to finalize, you know, what the study is going to end up focusing on. Another characteristic, and I was mentioning this before as well, in terms of this iterative design, is this idea that you would carry out data collection and analysis in parallel, and data analysis would generate emerging findings that you could feed back on an emerging basis, kind of through different feedback loops, right? And in doing that, you know, you're generating quite quick findings, but at the same time, there's different techniques that have been developed in the field to enable you to look at the data analysis process as one that has different dimensions, right? So having maybe a quick summary of what's happening, maybe even on a real-time basis if that was required, and then also developing an infrastructure within the study and also within your team to be able to carry out more in-depth pieces of work if that was needed as well. And like we've been discussing so far, quite a bit of reliance on team-based research to be able to develop you know, the study under the time pressures that we've discussed. Now, with lots of these different techniques and approaches, there's always challenges associated with these. And in this review where we've looked at the use of rapid ethnographies in healthcare, we've identified some key ones that I just want to discuss briefly to make sure that we're positioning these approaches in a critical way as well, right? Recognizing that there could be some limitations of applying these in practice. I think the key one is the first one around breadth versus depth in terms of data. So, you know, I think this is something that we encounter in any type of study, right, regardless of time pressures. But within rapid studies, lots of key decisions need to be made around design, where there tends to be a more tangible trade-off. So, you know, if we focus on, let's say, more study sites, if we expand our sample, we run the risk of not generating the level of depth in terms of our data that we would hope to achieve, or the level of depth actually that we really need to answer our research questions. So that is always there, and it's something that's important to consider in terms of study design. Several authors have also talked about kind of issues around sampling and the extent to which maybe sometimes teams using these approaches might not have enough time to, for instance, access more harder to reach populations, or might not be seeking the point of view of all of the kind of relevant stakeholders to some extent, and then the research might be then reliant on those who are easy to recruit into the study, for instance, and that, you know, of course, definitely presenting a kind of a biased view there. So that's something as well, and there's quite a few different techniques that have been developed to be able to look at sampling quite early on, and to design sampling frameworks to try to address some of these issues. Like we mentioned before, you know, this reliance on team-based research, there's definitely pros and cons associated with it. We've talked so far about the benefits, you know, in terms of covering more ground, in terms of bringing in different perspectives into a study, especially if you've got people from different disciplines, but at the same time, managing data collection, data analysis across multiple people, making sure that you are ensuring that there's consistency in those processes. All of that generates challenges. Sometimes you might also have team members with different levels of expertise in research. So just making sure that you're managing that is also a challenge, especially if you're also trying to deliver findings in a timely way. So quite a few approaches have been developed to ensure that consistency, and I'll show some examples when I talk about our COVID-19 research today. Key one, especially for more in-depth pieces of rapid research, we see this a lot in rapid ethnographies, for instance, is this idea that rapid studies will tend to be a lot more instrumental, potentially losing the link to theoretical engagement. There won't be time devoted to a more kind of reflexive approach, so the loss of reflexivity, or that kind of critical reflection of the researcher in relation to their own positionality and how that might shape the research process, right? So, and there's quite a few really interesting examples in the literature that have looked at that in relation to time. And what we find really when looking at how these approaches are applied in practice is, of course, as always, there's a mix, right? There's quite a few pieces that really do lack that theoretical engagement or that critical angle, or have not really touched on anything related to reflexivity. However, we do find some really, really nice examples that have done exactly the opposite. So in general, what we would say is really those potential limitations are not necessarily a product of time or a matter of time. They're more about the actual disposition and inclination of that individual researcher or that research team. And I'm sure I don't need to tell people on the call, but of course, a big barrier, especially to the rapidly set up and implement a study, always has to do with governance processes, ethical review committees, and that's certainly been the case for us as well during the pandemic. So I could talk about that for hours. So I'm going to skip on to my next slide. Okay, so now we get actually, after talking a bit more about that field of rapid qualitative research that I wanted everyone to kind of to be on the same page. I just want to introduce the study that we have been carrying out during the pandemic. And this is what we were faced with. So, sorry. So I think it was as early as maybe January or February in 2020, we started having some internal conversations within the team, thinking about what we were going to do with the pandemic as you know, news were spreading around the world. And some of the things we were considering at the time were, I mean, we were drawing from our previous experience with infectious epidemics, and we knew about the value of qualitative research in generating evidence that was different to what we would normally see in other epidemics used to actually inform epidemic response efforts. So we've got within our team, we've got a whole stream of work actually looking at qualitative evidence and how it's used or not in these types of contexts. So we were sure of that. We also knew that data that was captured in real time would not be the same as a retrospective piece. So we knew that if we wanted to do something, we had to set it up incredibly rapidly. And our hope was to be able to start some of the data collection even before that wave 1 of the pandemic hit the UK, to try to look at some of the expectations and some of the anxieties of healthcare workers. We knew we were looking at what was happening in China, Spain and Italy at the time, so we knew healthcare workers would be really affected as a result of you know, the impact on healthcare systems around the world. So we were expecting a similar trend, and we also had that knowledge that I have been talking about so far around the use of rapid qualitative studies, and particularly rapid appraisals, which is the design that we went with for this study. And we had already developed some techniques in the past to help us to be able to generate those findings and share them in a timely way. So taking all of that into consideration, this is what we decided to do. And we've published this piece already reflecting on some of these challenges if you're interested in talking about this particular study. And what we thought at the time is we wanted to do something that was, because of the questions that you see here, and I won't go over them, but mainly these questions are looking at healthcare workers' perceptions and their experiences, their main areas of concern. We knew this was going to be, to some extent, a more of a perceptions and experience study, because we couldn't actually go into sites to carry out observations and to see how things were happening in practice. So there was going to be an interview component to the work, but at the same time we also wanted to start drawing from some of the data that we didn't need necessarily to generate as a team, but that were already out there, and we wanted to be able to ground those experiences and perceptions in what was happening nationally. And that's where this idea of adding a policy review was incredibly useful. And so we reviewed policies all the way from December 2019. And we're still doing that. So we've kind of updated the policy review on a regular basis, and we've integrated that into our analysis in different ways. And I'll talk a bit more about it in a bit. But in addition to policy review, because a lot of communication, there was so much happening in the media, we decided to add a rapid media analysis to our work as well. And we divided that in kind of 2 main areas. So we did more of a mass media piece looking at an analysis of kind of more print media, newspaper articles, all that. And then we added a social media analysis that actually our team did not have expertise in social media analysis. So we partnered with a team at Oxford, and some of the people from Oxford are included here as authors, as you see. And they've got a team that specializes in social media analysis, and that was an incredibly useful collaboration. And I'll talk a bit more then about the mirror studies, because as we designed our study in the UK, we started to have some discussions with teams around the world to see if they would be interested in replicating the study. And so we came up with this concept of mirror studies. So the study being replicated, looking at healthcare workers around the world, kind of painting that global picture of what was happening. So we had lots of things to think about, as you see here, many of these quite practical things, so lots of logistics to sort through. We had no funding, for instance. We started to look for grants because we set up our study really early on. Also, lots of the funding opportunities that came later in the pandemic. I mean, many of the opportunities that were made available for COVID-19 actually came a lot later than when we were setting up. So by the time when these were made available, we did apply for some, we were not successful, but also we had already done quite a bit of data collection. So really that we had to fund that mainly internally with funds our team had already. We also had to build a team, and considering building a team with no funding is always very challenging. It was quite a unique time because lots of people had to put other studies on hold. We had students who could not carry out their original kind of research studies. And so there was quite a bit of shifting, people taking on topics related to this study instead, and people also volunteering quite a bit of their time. So that was kind of managed in those ways. Ethical approval, I mean, for this particular study, we didn't have any major issues. We considered service evaluation, but then actually went for a full HRA approval process. And other studies, we had lots of issues, but for this particular one, I can't complain about any of the ethics committees. And then a big thing that we had to consider really early on was about our sharing of findings and how we would be generating a rapid turnaround of findings. But we wanted to be able to share them in the UK so that they could be actively used during the pandemic, as well as to share them at a global scale. And one of the key things that allowed us to really develop the study as a quite rapid study, considering the sharing of emerging findings, was the fact that we've used different tools that have been developed in rapid qualitative research to provide a synthesis of the findings as you're collecting data, be able to bring those to team meetings, discuss them. As a result of that, be able to generate summaries of the findings to share with stakeholders if you need to at a very frequent basis, but also thinking of our team as an academic team to also be able to carry out more in-depth pieces of analysis and write those up for publication. Now, in terms of some of the sharing of those rapid findings, what we were doing, at one point, our team was asked to actually provide updates twice a week during some of the peaks, right? And that for qualitative research is incredibly rapid. And of course, you know, based on some of the techniques that we were using, we were able to do that. And so we were able to do some really good work with some of the organizations that I've listed here. And then a few months after we started data collection, we also started to liaise with other organizations in WHO and MSF, and trying to share some of our findings at that stage, and, you know, translate them to what was happening around the world. And one of the things that we did early on was, and this is an infographic that we developed after we had, I think it was a few months of data collection, really, to start to share findings really early on and sharing them in different ways. So, you know, being most of us being social scientists and working mainly with qualitative research, we're quite reliant on more kind of text-based approaches to sharing information. And we have been experimenting for a while now around the use of more visually, I guess, appealing ways of sharing data. And one of the things that we did was to create this infographic on emerging findings. And as you see that this bit in the middle around emerging findings, these were all of the main concerns that healthcare workers were expressing mainly in the interviews, but we were also seeing quite a bit of policy development in relation to these, and also the media data was pointing to them as well. And we developed this piece and we used it as a way of sharing them, first of all, with everyone who had taken part in the study up until then, as kind of a member checking process. And we got really positive response from healthcare workers, actually, you know, discussing how these findings resonated with their experience, but also appropriating the infographic in different ways, sharing it with colleagues. Some asked to print it out, to put it in staff rooms, sending it to other hospitals. So that became a really valuable experience for our team around looking at different ways of disseminating our findings. And so after we created that kind of big overview around, okay, well, these are kind of the key things that are emerging, then we started to do a bit more work to try to develop more in-depth pieces of work. So you'll remember some of the topics that we identified in that infographic. We then reorganized our team to create kind of subgroups for analysis, where each of those had a team lead, and that team lead kind of worked with a group to see what was out there in terms of literature, to look at potential theoretical frameworks that could shape that, and also to use, to go back to the raw data and see if we needed to tease out some more of the detail and develop, you know, bigger pieces of work. And some of that we continue to share in a very accessible and summarized way. And other bits of that we actually developed into articles for publication. So this is what I meant before in terms of adding these different subgroups. So the ones in red were our data collection teams that continue to operate even, you know, until today. We've got a whole second round of data collection happening at the moment, looking at how healthcare workers have experienced this last wave of the pandemic, long-term mental health effects. We're also looking at vaccination, you know, lots of issues that are relevant to this point of the pandemic, but also then organizing all of these other analysis teams. Some researchers working across many of these as well. So you don't think that we had a huge team actually working on this study. And one of the key things is what I was mentioning before, you know, one of the key characteristics of many of these approaches is the fact that we consider process of analysis as happening across many dimensions, right? So the idea that you can do a quicker kind of turnaround of findings, so a quicker bits of analysis to tease out what the main topics are in terms of, you know, from the data that you're generating, and potentially share that if you can on a real-time basis. But then also by maybe organizing the team in different ways, you can do some more in-depth pieces of work. And even within the more in-depth pieces of work, thinking about different temporalities, right? So I always mention the example of the work stream that we had on well-being and mental health, where we did a really quick piece early on to try to inform some of the developments of the well-being guidelines that were being implemented locally in hospitals. We then, after we had about 33, I think, interviews, we did another piece where we actually engaged a lot more with our data, and at the same time we carried out a review of the guidelines that hospitals had developed around the country, and tried to look at guidelines for well-being in relation to healthcare workers' actual experiences of well-being during the pandemic. And so we put together one quick paper looking at that. And now another piece that's still ongoing is even more in-depth piece looking at the long-term mental health effects of delivering care during this pandemic. So, you know, the same kind of work stream, but looking at different ways of analyzing the data, and it's very similar with some of the other work streams that I've included here on this slide. And that's led, like I was mentioning before, to different types of academic outputs as well. And the kind of the quick mental health, the quick well-being paper that I mentioned is the one that you see here on in green type. We did another quick analysis of everything that we had a few months after we started data collection, which is the top paper, BMJ Open, on perceptions and experiences of healthcare workers. And that was a way of bringing all three work streams together and just making sure that we could share those findings with an international audience in a timely way. And then two analyses that have taken a bit longer because we wanted, of course, to collect more data and to do more in-depth pieces, which are the two bottom ones here, looking at PPE and then looking at how experiences have been shaped by gender. And like I was mentioning before, different ways of disseminating findings as well, looking at emerging findings, as in the slide we've already discussed, but then as we've created more in-depth pieces, I've mentioned some of the work on PPE and also being able to develop like the one-page infographic that you see here to share those findings with various organizations. And then, you know, academic outputs, but even when we produce a paper, we tend to produce a visual abstract like the one that you see here in the middle in orange, where we try to summarize the key findings from that paper and to present it in a more visually appealing way. And then, of course, signpost people if they want to read the full paper that they're able to look at that. And so coming back, I guess, to then expanding beyond the UK, so this idea of mirror studies that I mentioned before. So we knew we couldn't do, we couldn't design this as a comparative study. There wouldn't be time, we wouldn't have the possibility to actually do that in practice and still set up all these studies. So what we did here is, after we had already designed and had gotten approvals to do our study in the UK, we started contacting other teams around the world that we knew were doing other similar pieces of work or had some expertise in these types of research approaches. And we asked them if they wanted to replicate the study in their countries, just saying, you know, here's our protocol, here's all of our study documents, do you want to do something similar? And as you can see, many countries said yes. We had about 15, at one point we had about 22 countries, and then various different reasons. We ended up having, I think, about 15 to 17 in the end actually replicate most of the work that we did here. Of course, with lots of adaptations to their different healthcare systems, to the expertise of the people on their teams, to the needs in their countries as well. And it ended up looking something like this. So quite a few countries looking at replicating mainly the telephone and the policy review work. Some have also incorporated media analysis, but not as much. And this is a network that meets, is continuing to interact. And the only thing that we said, you know, after sharing our study documents was that we wanted to form this global network where we could come together and when countries had emerging findings, that we could actually share them as a collective and learn from what was happening around the world. And this is a network that meets every 2 months, and we take turns sharing emerging findings from our studies. And at the moment we're doing a piece where we're trying to bring all of that together, kind of paint a global picture of the experiences of healthcare workers during the pandemic. Just some examples of global reach. So the global network has, you know, as a result of these different collaborations, different teams have been able to apply and to become, you know, to be successful for funding applications to kind of further deliver their projects. Different partnerships have developed. Countries have shared findings from their studies with different local organizations. And we're now, as I mentioned before, working together to develop an edited volume that can bring everything together. So last slide here, sorry, I think I've run just a few reflections in terms of challenges that still remain. I mean, we talked about a field that's already developed quite a bit, and the fact that during the pandemic, quite a few people have become interested in these types of approaches. But there's still lots of challenges here around potential burden that could be generated with the real-time data collection. You know, our study focused on healthcare workers who are already quite pressed quite pressured, sorry, at this time. And so we're kind of adding this as a burden to them. The real-time sharing of findings, you know, there's always questions around when is it appropriate to start sharing findings, when do I have enough or good enough data? It's a question that we always come back to. Even though we've noticed quite a few changes around the way in which qualitative data are I guess, conceived, or the extent to which their value is recognized, we've seen lots of improvements, I think, with this pandemic. There's still lots of tensions here around the validity, I guess, of qualitative studies and how we might be able to create findings that could actually be easily translated to inform the epidemic response efforts. And as I mentioned before, we continue to find lots of barriers around ethical review processes. And many times, even though as research teams, we want to design and set up studies quite rapidly and be very responsive, we continue to face lots of barriers around the existing kind of academic infrastructure and kind of research infrastructure. All right, sorry, I've talked for like, it seems like forever. I'm really happy to take any questions if you've got them.